So I liked the data that we was shown at EHA, in the sense that we have the FLAIR update that showed that there was superiority in the group that received ibrutinib plus ven when compared to FCR or ibrutinib. The ibrutinib-ven combination reduced the risk of progression of death by 87% compared to FCR. Again, we had that data from the E1912 that was done in the United States. Even though this study was done later on, it's interesting to see that this study was done when there were other drugs that were available. Like when we did E1912, venetoclax was not yet approved. And so there was a survival advantage, whereas with the FLAIR, venetoclax was already approved and it could have been used as a salvage therapy. That's one of the studies that was presented. The other study that was presented was the Captivate-2 longer follow-up. The combination showed that, like the 5-year PFS estimates are still really high. And the CLL13 analysis was also presented, showing that the combination of ibrutinib with obinutuzumab and venetoclax also showed excellent 5-year PFS estimates. The concern is that for those patients with unmutated disease or TP53 mutation, these patients tend to continue to show earlier relapses compared to everyone else. And I don't want to forget ATM deletion or 11q deletion. That also correlates with a shorter remission duration and in fixed duration treatment strategies. So we still have that concern, but again, these are fixed duration treatment strategies, so the patients are able to live a life without any therapy for years, right, on average. So whether I would be willing and comfortable challenging with the same regimen, it's, we have now data that yes, it's possible, and many of the patients do respond well. Dr. Matt Davis presented data on the Revenge trial where patients are exposed again to venetoclax and you can retreat. So one question that I always get asked is, do you do fixed duration treatment strategy, or do you re-challenge with single agent and then you can do continuous daily dosing? And I think at this moment, it really depends on the patient. For example, I have a patient that was on the Captivate-2 trial, and he's starting to show some, he's young, he's only 40, and he started to show some signs of progression. He's not there yet to be started on therapy, but when asked, he's like, listen, I don't want to change my life. I still want to do a fixed duration treatment strategy. But for someone that is older, I would probably be more inclined to just give them a continuous daily therapy. So I think the field is evolving because we still, all these mature data are just appearing in, and we're trying to make sense of how we best and optimize the therapies for our patients. I think that fixed duration treatment strategy is the way to go moving forward for patients that are young and healthy and fit and are willing to do a little bit of more intense monitoring at the beginning of the study or the regimen, because they might develop TLS or other toxicities. Now, I'm not convinced at this moment, based on the data that I've seen, that the addition of obinutuzumab should be done on everyone because of the concern for more potential toxicities, including infection risk. And that has been seen with patients that were treated during the era of COVID, and many of them did not have a good outcome. And not only infections, it can also cause more toxicities in terms of thrombocytopenias or prolonged immunosuppression. So I'm still not embracing the triple therapy regimen, but it looks amazing. It's just that it comes at an added cost. And many of our patients, even on that data that we presented, most of our patients are in their late 60s, 70s still. We do have some younger people, but but it's the minority. And so for a young fit patient, yeah, absolutely, no questions asked. But for an older patient that just, like they're used to also taking a pill for the blood pressure or diabetes, I wouldn't push for anything too aggressive, because achieving a deeper MRD might be good in paper, but it comes at a cost.